Welcome to Decoding Healthcare Research, a podcast by Agora Project. Join us as we delve into the behind-the-scenes world of groundbreaking research and the dynamic healthcare industry, interviewing top paper authors, engaging experts on industry-related topics, and exploring medical subjects that affect our daily lives. And now, your host, Dr. E.F.
Welcome to Decoding Healthcare Research. I'm your host, Efrain Riveros, Dr. E.F. Today, we are going to be talking about coffee, physical frailty during the elder years. And this topic is of particular importance, and we have an expert here. We have Dr. Woon Puay Koh. She's a professor in Healthy Longevity Translational Research Program at Yong Lin School of Medicine at the National University of Singapore. She's the principal investigator of the Singapore Chinese Health Study. Welcome, Dr. Koh.
Thank you very much for having me here today.
Thank you so much. So we came across a paper, and we are going to center our discussion on this article. But beyond that, Dr. Koh is going to tell us a little bit about all the experience that she has investigating this topic. So the title of the paper is Consumption of Coffee, Tea, and Caffeine at Midlife and the Risk of Physical Frailty in Late Life. It was published in the Journal of Post-Acute and Long-Term Care Medicine in 2023. So first of all, before we go deeper into the paper, Dr. Koh, what motivated you to study the relationship between coffee and physical frailty?
So I think the motivation comes from three reasons that I'm sure all of us are familiar with. The first is that the world is aging. Population aging is a problem in many parts of the world, in many countries. It has been projected that, in fact, by 2050, except perhaps for the continent of Africa, 1 in 4 individuals will be above the age of 60. Well, I probably may not be around, but if I were, I definitely belong to that 1 in 4. And we know that with aging comes a decline in function that so many of us dread: physical, cognitive, even psychological and social frailty, which is defined as diminished function that brings about increased risk of diseases and eventual death. So the first reason is that this aging, how to prevent adverse outcomes and how to keep population healthy as they age, is of pertinent interest, not just to me, but to a big community of scientists and doctors out there. And the second reason comes from the fact that coffee, as we have just discussed, is probably the third or the second most commonly drunk beverages. The first being water, and then tea and coffee are just really close second and third. Commonest beverages that we drink. A lot of them say that I can't start my day without my cup of coffee. And so it is, and this is interesting because just by searching on the internet, is coffee good? How many cups of coffee should I drink? You have millions of hits showing how people are intensely interested in just wondering if what I drink a day as a habit is going to harm me or give me benefit. So we decided that coffee is definitely a topic of worldwide interest that people will want to know. And the third reason is because I have a cohort that will give me the data to do so. So I'm the principal investigator of a cohort in Singapore, which I think will provide important, good data to give us robust results to tell us what the association is between drinking coffee and tea or tea daily and an important outcome of aging, which is physical frailty. So these are my three motivations.
And it's exciting, and it's clear that the fact that you have this cohort of patients and the follow-up period is significant. Definitely gives strength to the findings that you have. So let's go into the study here. Can you tell us a little bit about the study design, the participants, and all the details of the methodology?
Yes, with pleasure. So this is a cohort of healthy individuals, not patients, but healthy individuals living in Singapore. So Singapore is a multiracial country, but we are really predominantly a Chinese community. 78% of the population are Chinese, and he has remained so for decades. And the Chinese are all originally migrants or children of migrants from China. And a large part of Chinese in Singapore are migrants from southern China. And so they mainly came in the 1920s, around the time of 1920s. And now, of course, they are citizens of Singapore. Like, for example, my own grandfather migrated from Fujian, a southern Chinese province, to Singapore in the 1930s. Of course, now I'm third generation Singapore Chinese living in this country. So in between 1993 and 1998, which is really about 30 years ago, my mentor and my chair of Department of Public Health at that time in the university, together with Professor Mimi Yu, who is a renowned epidemiologist scientist from the University of Southern California in USA, met and discussed the setting up of a cohort in Singapore to study diseases common to Chinese. And of course, you'll be wondering, why would a American professor, no doubt herself a Chinese, Professor Mimi, you'll be interested to study diseases affecting Chinese in Singapore? And that's because, if you think of Chinese now, practically they, as an ethnic group, as an ethnicity, this group has migrated, and now the joke is that every corner of the street you can see a Chinese restaurant. So there's a large community of Asians, Chinese representing Asians, who have migrated to America and to other parts of the world and become residents of these countries. And so when we study diseases important to a big ethnic group, we actually study diseases that affect large populations spread across the world in many countries. And of course, we have a large population of Asians now in America. And so, but why Singapore? That's because the first intent of this population was to study cancers more common in Asia. For example, nasopharyngeal carcinoma, liver cancer, and gastric cancer. And so we have the opportunity to do this in Singapore, because Singapore is a small country. We're a very small country, but things are then well recorded, and it's easy to follow up on people's lifestyle and on their well-being. We have very well-established national disease registries that will allow us to be able to track outcomes. And also we are able to revisit the participants easily to follow up on their lifestyle and especially on change in their health. And so the population was formed. This cohort was formed in Singapore between 93 and 98 by the recruitment of about 63,000 Chinese living here, living mainly as residents in the government-owned, government-built public housing estates. And the recruitment when we recruited them about 30 years ago, we collected detailed information about their lifestyle, about their usual diet, about physical activity, the use of alcohol, cigarette smoking, their medical history, and details about the drinking of coffee and tea. And Singaporeans, being Chinese, we drank not only green tea, we also drank black tea, And so, we were able to study not just coffee, but green tea and black tea individually and together. So between 1993 and 1998, we visited and recruited 63,000 Chinese. And after following them up for about 20 years, between 2014 and 2017, we revisited about 17,000 of them. And this time, when we started the study, the average age was 53 years old, 53. But Singapore was quite different at that time. 30 years ago, people retired at the age of 55 in Singapore. When we revisited them between 2014 and 2017, it was the third time that we went out to visit our participants in a big way. And for the 17,000 that we visited, it was the third time after recruitment that we were talking to them again. And at that time, the average age was already 73. So imagine meeting a friend in his 50s, 53. 20 years later, re-meeting this friend when he's in his 70s. And then you're looking at this friend and saying, let me see if you are aging healthily. And that was what we did at the third visit. When we visited these 17,000 participants, they were in their 70s. They were actually, of ages 63 to 99, but the average age was 73. And we measured their aging outcomes. And one of the things we measured was their physical strength, their physical function. And, we came up with an outcome called physical frailty to see how many of them were considered to be physically frail by specific criteria that we had. And then it was really just building the model and doing a statistical analysis to see how the outcome of physical frailty was related to the amount of coffee, tea, and caffeine consumption when they were much younger in their 50s. So this is basically the study design. A longitudinal study, first collecting data at the age of 53 on average, following them up over 20 years, and then measuring the outcome of physical frailty in their 70s.
For our audience who might not be familiar with the term frailty, what does physical frailty encompass?
Physical frailty in this paper, we did, and elsewhere, is quite widely accepted as a definition of an age-related medical syndrome, characterized by diminished strength, endurance, and reduced physiologic function, which increases an individual's vulnerability for developing increased dependency and death. And, the irony is that if you ask 3 doctors or even just 2 individuals, myself and you, we would look at these 2 photos of 2 elderly and agree that they look frail. But if we are each asked to define why we consider them to be frail or define frailty, our definitions may vary, but we could all kind of agree that indeed they look frail. In fact, here's a picture of the late Queen Elizabeth II from England, and this is one of her last pictures before her passing. And this is what the caption in the newspaper read: that the Queen looked frail but happy in final photos. And if you looked at her, well, we could all agree she looked happy, she had a smile, but the frailty probably was conveyed by her posture, slightly stooped. She was holding a walking aid, and so it is a kind of a definition that really comes with, a sense of reduced muscle strength, reduced muscle function, and it is closely linked to sarcopenia, which really means reduced muscle mass and function. It's those who have physical frailty progressing faster with aging. It is a personal, family, and healthcare burden. It reduces quality of life in old age. And therefore, there's so much interest worldwide amongst medical, scientific, and even the lay community to see how we can prevent or slow its progression. So in this study, we used 4 criteria to define frailty. So participants who had 2 or more of these criteria were considered to be physically frail. And so these 4 criteria really, again, kind of define the components of frailty. The first is weight loss. And so this weight loss definition came by comparing the weight that we had from follow-up 3, when we measured their physical frailty status, and a follow-up with them about 6 years prior to this. So prior to 2014 and 2017 follow-up 3, we had another follow-up with them where we asked about their weight. And so we went back to the weight about 6 years or 7 years ago, and we find that if they found that there was a loss of 10% or more, that was considered significant weight loss. And I think unless it's intentional, losing more than 10% of weight loss is clinically significant. The second criteria comes from the answer to the question, do you feel full of energy? And for the participants who said, no, I don't feel that, we define that as exhaustion, and that was another criteria. The third criteria was slowness. And for this, we measured the time that they took to do a simple test for us. So we asked each participant to sit down in a chair, stand up, walk across 3 meters in a room, turn around and walk back. And this is a standard physical test known as the time up and go test. And then we then define the people who were in the slowest 20% of the group to be considered slow. So that was the definition of slowness. And finally, for weakness, we asked them to do a simple hand grip strength for us with an instrument. And those who were the weakest, those were the weakest grip in the 20% of their gender, where the men or women were considered to be physically weak. So if they had 2 or more criteria out of the 4, they were considered to be physically frail for the purpose of our study. And this was present in about 15% of our study population, of close to about 2,000 individuals.
I think it's very thorough, your explanation. And before we go into the results that are actually very intriguing, can we talk a little bit about coffee? What components of coffee have been associated with the good outcomes and the benefits?
So coffee has been, extensively studied. And if you just search the literature today, you'll be surprised, or perhaps some people may be surprised to know that coffee has been studied all the way from cancers to cardiovascular disease to diabetes, and I think this really stems from the fact that coffee is such a common beverage that a lot of us would at least drink a cup a day. In fact, in my population, of 63,000 Chinese, in the middle age and elderly in the 1990s, we had about 68% of 63,000 reporting that they drank coffee daily. So it's just, it's a really common beverage. And amongst those who drank daily, about half of them drank 1 cup a day, and which means that the other half drank more than 1 cup. In comparison, even though they're all Chinese, tea was less commonly drunk. Tea was, we had about 37% who said that they did not drink tea even once a month. So tea was not something that they drank frequently. We only had about 24% who said that they drank tea daily. And amongst the daily drinkers, 62% said that they would just drink 1 cup a day. But what is common between coffee and tea? And immediately the word caffeine comes to mind. But really, coffee and tea are not just caffeine in water. Both coffee and tea are packed full of polyphenols and chemicals that scientists are still trying to isolate and study today. And so the polyphenols in coffee, have been, associated with health benefits in reducing the risk of diseases like diabetes, cardiovascular disease, even in cognitive impairment, there are some studies have shown that it's good in reversing, in slowing down certain adverse outcomes of aging. The catechins in green tea and black tea have been, and the catechins in black tea have been studied extensively and linked to reduced risk of cancers. And so, but caffeine itself, common to both coffee and tea, caffeine itself have also been associated with outcomes like a reduced risk of Parkinson's disease. And for this case, we have found that it could actually, have some effects on the muscles. So when we looked at the literature, we found that not only have epidemiologists like me studied caffeine, the effect of caffeine in health, experimental scientists have actually taken caffeine, put it into cells to study in vitro effects, and have given it in forms of coffee and tea to animals like mice to study effects in animal models. So we're very excited to see that studies have been published where caffeine was put into myocytes, into muscle cells, and shown to increase DNA synthesis and in cell proliferation, causing the myocytes or the muscle cells to grow in vitro. And experimentalists, animal scientists have actually given coffee to old mice, and compared to old mice given water, the old mice who had coffee had reduced muscle loss, had better muscle function, and again suggesting that there was effect on the muscles of the animals. Before we did our study, we've also looked at human population studies, and we found a study in Spain that looked at coffee drinkers and non-coffee drinkers and compared to physical function, and showed that those who drank more coffee a day had better physical function, although the follow-up was quite short. And finally, we also came across a study in China. In China, you might think everybody drinks tea in China, but they were able to compare daily tea drinkers to those who didn't drink tea daily, and found that those who drank tea daily also had better physical function. So there were clues out there, from animal studies, from in vitro data, suggesting that caffeine, common to coffee and tea, could have good effects. And some suggestion from human studies. And also separately, we know that coffee and tea could have good effects to reduce risk of chronic diseases, which they themselves could also be factors of physical frailty. Yeah, and so, we went in. So are we surprised at what we have found? No, we are not, but we are truly glad with our findings.
Yeah, absolutely. And it's interesting how, even the process of fermentation for the tea and the roasting process for coffee may change some properties, but still the polyphenols remain and their beneficial effect is there. And I want to move on to your study. Let's talk about the findings, because what you found is just mind-blowing. So can you tell us a little bit more about the results?
The limitation of a human population study, like what I've done, is that we cannot be sure what the ingredient is. We can only look at an association. So we really need studies in cell cultures, in animal models, to decipher the underlying mechanism or to identify the right ingredient. So association studies like these could only give us a clue. So we can't tell at the end whether it was truly the caffeine or the polyphenols. But because we were only able to study what we could collect data of. And also we collected data about coffee and drinking. We also collected coffee and tea. We also collected data about the intake of other caffeinated food items. For example, energy drinks, certain soft drinks contain caffeine. Chocolate has a little bit of caffeine, and we like cocoa. And so we also collected data on the intake of these other caffeinated food and beverages. But in this population that we had, middle-aged and elderly Chinese, we had a good, over 80% of caffeine consumed in this population really just came from coffee and tea. So the first thing we did was, to look at each individual from his or her intake of coffee, tea, and the other caffeinated food and beverages. We sum up from the questionnaire an intake of daily caffeine. So this is an estimate of consumption of caffeine from all the caffeinated food, beverages, coffee, and tea. And then we put people into 4 groups by their intake of caffeine. So those in the lowest 25%, the second, the third, and the highest 25% intake. And we decided that before we looked at their outcome, we should just see whether people were different by how much caffeine they consume. Some people say, oh, you drink too much caffeine, you are, too easily excitable, you're the more energetic type, and so on and so forth. So we wanted to see whether just by choosing how much caffeine you take, people may be different in other ways. So we looked at people in yellow. They were the people who were the lowest 25% intake compared to the people who were the highest 25% intake of caffeine. These were probably the people who drank a lot more coffee and tea. And we found that, first of all, compared to those who were the lowest intake, those who had the highest intake of caffeine were more likely to be men. So men had higher intake of caffeine. They were also more likely, therefore, to be smoking, drinking alcohol, to be participating in vigorous works or strenuous sports. So you might say, yeah, you probably see that more common in men. In terms of age assessment, the age was, as I said, that by the time we went back to measure their physical frailty, they were all, in their they were ranging from 63 to 99. The average age was 73. And we also found that because, they were more likely to be men, they also had higher risk of some cardiovascular diseases and so on and so forth. So we really don't know whether these differences were related to their caffeine intake or rather related to the characteristics of the people who took more caffeine, but they became important in the consideration of our analysis. That it was important, therefore, that when we looked at the intake, sorry, let me just let me just go to that slide. Yes.
Mm-hmm.
That when we looked at the analysis, it was important for us to carefully consider all the other differences, that could be apparent between people who took more caffeine and people who took less caffeine. And then when we looked at coffee and tea separately, we also had to make sure that when we looked at the consumption of coffee, we had to consider and adjust for tea intake. That's because people who drank more coffee would drink less tea, because there's just so much, how much beverage you could take a day. And so these were important differences that we had to carefully consider in our analysis. So let us look at the results. So again, as said, we first looked at coffee intake. So when we looked at coffee intake and we adjusted for the other differences and we adjusted for the difference in the tea drinking, we found that compared to those, the 32% who didn't drink coffee daily, those who drank coffee daily had reduced risk of physical frailty. So again, this is coffee drinking at about 20 years ago, at the age of 53 average, and looking at physical frailty at the age of average age of 73. So compared to those who drank 2 to 3 cups a day, the risk came down to close to 10%, but was not reaching what we call statistical significance. But when we looked at those who could drink 4 cups or more per day, so 5% of the population had 4 or more cups per day of coffee. And compared to those who didn't drink daily, their risk of physical frailty came down by almost half, came down to 0.54. And this was the same. And remembering that we actually had coffee, and this was what we saw. Then we went to tea. So for tea, we were able to look at 4 categories. There were people who didn't drink tea at all, not even once a month. Then we had people who said, well, I may drink a few cups a month, but not more than, less than once a week. Then we had people who drank tea a few cups a week, but not daily. And finally, we had, that 23% who drank tea daily. And again, we see a very nice dose-dependent reduction in the risk of physical frailty as people drank tea more frequently. Now, you may wonder why we didn't look at cups of tea, but only at frequency. And that's because it was an interesting phenomenon. When we asked people how much tea they drank, a lot of them said, oh, I just keep topping up the water, what we call steeping of tea. And we don't do that to coffee, of course. 1 cup is 1 cup. And so because it was very common, especially in green tea or Chinese tea, to just keep adding water, it was difficult for us to really know how many cups to consume. And therefore, we decided to just look at frequency of tea. And when we sum up caffeine intake, and we looked at, the amount of caffeine and the risk of physical frailty, we found that compared to the lowest 25%, when people had higher intake of caffeine, the risk of physical frailty came down very nicely in a dose-dependent response. So compared to those who were in quartile 3, the top 50th to 75th percentile, the risk came down to 0.83. And those who had the highest caffeine intake in the highest 25%, their risk was reduced to 0.78. So of course you might be wondering, so how many cups of coffee or tea is that quartile 3 and above? So to reach quartile 3 and above, for the amount of caffeine inside, it would be the equivalent of about 2.4 cups of coffee or tea daily. So, you might say, well, who drinks half a cup? So this is an average, because we allow, the way we collect the information, we allow people to tell us, even if they, allow us to tell us an estimate of cups of drinks, 2 to 3, or over a week. We submitted it to be about 18 cups per week, which was about 2 to 3 cups daily. So it could mean, some days you would drink 2 cups, and some days, maybe on the weekend you would drink 3 cups. And then that's the essence of our results. And what's amazing is that we found that for the 4 criteria that we used, we found this association to be seen across most association, but especially for the ones that we measured. We found this association to be significant for caffeine intake and slowness, which is the time they take up to walk across the room, and also for the risk of being weak in their strength. And so for these two measured, criteria, the association was statistically significant. We also saw that also for the report of weight loss, as well as for the risk of exhaustion, that with more caffeine intake, there was lower risk of a significant weight loss and lower risk of exhaustion, although the results did not reach statistical significance.
That's super interesting. So it calls my attention. Well, the results are impressive, but I want to focus on the effect on slowness and weakness. Why do you think those two in particular were more affected? Is this related to the fact that there is a direct effect of caffeine on the muscle? What do you guys think?
Well, first, of course, from the methods perspective, out of the 4 criteria, 2, the slowness and the weakness, were criteria that we measured. So we didn't tell the participants, do you feel slow? Do you think you're slow? Are you weak? And so it wasn't relying on self-report, but it was truly a measured outcome. We asked them, we measured their grip strength in the instrument, and we recorded the time they took to walk across the room. So I think with better measurements, the results were therefore more likely to be accurate. And it is therefore more likely for us to see an association when the measurements are more accurate. The other 2 are self-reported. Weight loss, was a measurement of the difference between 2 reported weights at 2 different time points, but it was still self-reported. And exhaustion, of course, was just how they feel, was how they felt about being full of energy. So I think the other 2 outcomes could be weaker because we didn't have accurate measures, unlike the first 2. But of course, we also feel that it could be biologically explained. And so the biological plausibility is, again, going back to what the experimental scientists have shown us in the lab about the effects of caffeine or coffee in cell cultures of muscle cells and also in the animal models in aged mice, that caffeine in coffee and tea may truly have an effect on muscle cell division, on muscle function and muscle growth, and therefore was better related to these 2 measures, which really reflected muscle function and muscle strength, grip strength, and the gait speed, the walking speed. Yeah.
And what about the differences between men and women? Did you find anything in that regard?
No, so we looked at the results separately. We looked at the results in men alone, association among men, the association among women. We also looked at the results by difference in obesity. We looked at those with higher BMI, those with lower BMI, and we also looked at results separately by their age. So they were average age was 53 at recruitment. So we looked at those who were below 55, the younger people, the younger middle age, and then we looked at the older middle age, those who were above 55. And we did not see the results to be different between the 2 groups in the 3 different analyses that we have done. So the associations were seen in both men and women, in both people with higher and lower BMI, and in the older or younger people at midlife.
So for someone in our audience, probably this is very compelling, and they are basically called to increase their consumption of coffee, I bet. But from the public health perspective, what do you think are going to be the implications of this for the public health policies?
Thank you so much for this question. This is so important that I must answer with a slide to make sure that I get the right message across. So first of all, I am not here to advocate drinking more coffee or tea or taking more caffeinated food, like what a doctor would do for exercise or for taking medication. So it is not the same as telling people to exercise more. It is not the same as telling people to eat healthily. It is not the same as telling people to take medication if they need to for hypertension, diabetes, or chronic disease. Okay, let me get this out loud and clear, that I'm not telling people that they should start drinking more coffee and tea and caffeinated food. And that's because these are beverages that should be enjoyed as part of life. This is what I think, and this is what I abide by. They are not meant to be medication or supplements, for health effects. And so my conclusion, my message going out there would be, for those who enjoy drinking coffee and tea, they should continue to enjoy them without worrying, oh, is this harmful for me? And they should just go and enjoy the coffee and tea, and enjoy as much or as little as they could tolerate. Caffeine definitely has an effect on the central nervous system, on the sympathetic system. People who drink who are sensitive to the effects of caffeine may find that it affects their ability to sleep soundly, affects heart rate. Some people feel a bit jittery, they get palpitations or increased heart rate. If they experience that, then truly they are sensitive to the effects of caffeine on the sympathetic or on the central nervous system or the cardiovascular system, then they should limit the intake. So, people who don't have this and they enjoy the coffee or tea, go out and enjoy them. 2 to 3 cups a day is good for health. Some studies have even shown that 3 cups to 5 cups is what's recommended for cardiovascular disease benefits. And so that will be the first message. If you enjoy coffee and tea, continue to enjoy them. If you don't tolerate them well, if you don't enjoy them, don't add them. They're not medication. They are not supplements. Those who enjoy drinking sugar beverages, those who like to take the soft drinks, energy drinks with high calorie, should actually consider replacing them with coffee or tea for the same benefits of caffeine. And in addition, coffee and tea have other polyphenols, which may truly be the beneficial effects, the chemicals of the beneficial effects that these other sugar beverages may not have. And so finally, of course, to the scientists out there, we need to do more research to truly identify or pin down caffeine as the beneficial chemical. Or it could actually be other polyphenols in the coffee and tea. They are responsible for the reduction in risk of physical frailty. So more work is necessary. We need more studies to replicate our findings. We need more scientists we need more, science, more research in the laboratories, in animal models to tell us exactly what that chemical compound could be. And perhaps in the future, that compound could be extracted and, be, developed into supplements that could help people reduce the risk of physical frailty without worrying about having to tolerate or drink coffee or tea. So these are things that could be done in the future, but at the moment, if you enjoy coffee or tea, drink it and enjoy healthy longevity.
Yeah, and I like that point of enjoying. Actually, and this is my personal experience, because in my country, coffee is part of the culture.
Yes.
I'm from Colombia, so we drink coffee not so much as a central nervous system stimulant, but as a social opportunity. It's an opportunity for you to talk to other people, and I think that in itself is beneficial, besides the chemical effect of the coffee, and that's great actually. And I think your message is very clear, and I think it came across very nicely. You mentioned about future research in the lab. What about population studies? Do you envision more research in that field?
Yes. I hope that our studies would will motivate other population health scientists with similar cohorts, follow up over a long time, to also look at how diet, not just coffee and tea, but how diet affects outcomes of aging. And we really need diversity in the populations that we study. So again, just to, if I may just share just one picture of the coffee and tea that is drunk in my population. So it's interesting. So, in Colombia, the coffee being served may look quite different from the coffee that you may drink in Paris, for example. Definitely quite different from what you would drink if you walk down the streets of any street in America with Starbucks along the way. So in Singapore, especially 20 years ago, when this study was done, 30 years ago when this study, the data was first collected, there were no Starbucks in Singapore. Now we do. We do have Starbucks and coffee, tea, and coffee and tea leaf, cafes, in the community. But the main bulk of coffee was just drunk in humble coffee shops. And it is just brewed right on the spot in the kitchens of these coffee shops. And it's just simple water, coffee beans percolated through a coffee bag. You know, you can see that the coffee brewing is quite different in Asia. And, you know, a lot of the people in my population, you know, in my study population, just drink very simple 3-in-1 or 2-in-1 packet, you know. And for the true coffee connoisseur, you know, they might say, oh, this is not coffee, you know, this is not drinkable. But, you know, this is what a lot of the participants in my study, they drank this simple 2-in-1 packet, 3-in-1 packet, pre-mixed, just adding water. And so we were delighted that despite the different ways of brewing, despite even the difference in the subspecies of the coffee beans, the health effects, physical frailty was still observed. So we need diversity in populations. We need people who collect data and study decaffeinated coffee. We need people who study, you know, the drinking of, you know, beverages from herbs and flowers, like chrysanthemum flowers. We really need diversity of different beverages to tell us exactly what ingredients or what other drinks, what other beverages may be beneficial for health. And this is important because this has, you know, big public health impact. And so I just want to show again some of the, you know, the beverages that were asked. And when it comes to tea, we used to think that there was just green tea and black tea. And now, if you talk to someone, you know, who's an expert in tea, you will hear that there is white tea, there's yellow tea, there's green tea, there's, and then there's black tea, different grades of tea coming from the same tea leaves, exactly because there are differences in the processing. And with the differences in the processing, the polyphenols, the catechins in the tea change as well. And the effects, therefore, on health may be different. And all these really need diversity in populations to be able to reveal to us what the differences can be. Yeah. So, you know, lots of things that we could see.
Yeah, absolutely, and I'm excited to follow up on the research that you are doing, and this hour has been an absolute pleasure, and I feel honored to having had the opportunity to have you here, and I think the message was very clear. The study has definitely high impact, and our audience, I'm completely sure they're going to enjoy this episode. I want to thank you, Dr. Koh, for this time and your wisdom and sharing your knowledge with us. And I think we can wrap up this way. And for our audience, don't forget to leave us the feedback in the comment section, and you will find a link to the paper that we discussed today and some other papers of Dr. Koh in the description. See you in the next episode. Thank you, Dr. Koh. This was great.
Thank you so much for tuning into this episode. If you enjoyed it, please don't forget to give us a thumbs up and share it with your friends and family. Make sure to subscribe to our channel and hit that notification bell so you never miss an episode. If you have any questions or thoughts about today's topic, we'd love to hear from you. Feel free to leave your comments down below. For more information and references related to today's discussion, you can find them in the video description below. We appreciate your support and look forward to having you back for our next episode.